Okay. I'm going to go ahead and get started. Okay. So welcome to the Public Health and Psychology Division 4. We have four presentations in this division, and at the end of each presentation, we'll take questions from the judges and then the audience. You may ask your questions through the chat or use the Zoom raise hand feature and then wait to be called on. Before we begin the presentation, we already had the judges present themselves and mention their research fields. But yeah, we can go ahead and start if you guys are ready, and we can start sharing the screen. So if y'all want to get your presentation up. Okay, our first presentation is by Michael, Alex, Arav, and Malay from Baylor University. And is Malay in the Zoom?
Yeah, I am.
Okay, sorry, I didn't see you. Okay, you guys can go ahead and start your presentation whenever you're ready.
Okay, good morning, everyone. This is our presentation on the development and validation of a low-cost virtual reality-assisted laparoscopic intestinal tumor removal surgery simulator. To start off, I'm going to be giving a quick introduction and background. First of all, virtual reality has been proven to increase confidence in surgical residents. Additionally, virtual reality is expected to play a large role in medical and surgical education because how it is low cost effective when compared to traditional models, repeatable, and standardized clinical training on demand. However, most surgery simulators are too expensive and not consistently accessible. To this end, we developed a low-cost virtual reality-assisted surgery simulator, and it will be a beneficial and feasible addition to the medical and surgical educational model. This figure shows how virtual reality training increased surgical performance in orthopedic surgery residents. Currently, virtual reality is used in the training of medical students and surgical residents. Specifically, most trainers are used to simulate endoscopic, laparoscopic, and percutaneous procedures. The initial setup price is outweighed by the reusability and mobility of virtual reality simulators. Also, there's been a recent push for more open source information sharing to promote quicker simulation creation. The future of virtual reality in surgical simulation is promising, and we're really interested in investigating this.
And so the main supplies used to engineer our re-envisioned laparoscopy surgical simulation was an 18-gallon storage tote to simulate the body cavity, a garden hose to mimic the small intestine, as well as a Google Cardboard and a Lenovo Mirage camera, which has unique VR capabilities. And along with these materials, standard laparoscopic equipment, including trocars, Marylands, and endoscopes were used. And so a study of human anatomy and specifically the small intestine prompted a multi-port surgery, which is why the box has multiple holes on the lid. And so within the box itself, the hose was looped in a 2-level concentric circle. And prior to placing the hose in the box, several cutouts were made and filled with rubber triangles to imitate tumor masses. And these rubber triangles are common practice from the pegboard transfer practical. And so we made 6 openings in the actual hose itself, but only 3 pegs were placed inside. And so participants were tested over the span of 3 days in a controlled environment. And they were told that a 75-year-old man presented into a surgical outpatient clinic with abdominal pain, nausea, and melena. And the esophageal endoscopy and colonoscopy came out unremarkable. And so a computed tomography scan revealed multiple masses in the small intestine, eventually leading to an urgent laparoscopic resection. And so after being briefed with this case study, subjects were instructed to watch a walkthrough demonstration and complete a pre-survey questionnaire where they answered generic questions about their gender, age, and hand dominance, as well as specific questions about their VR experience. And so to begin our experiment and prevent any fluctuations between our control and experimental data, participants were given 5 minutes to explore what approaches or methods they seemed best fit to complete the exercise. And so after this free range time, students were given a total of 5 minutes to locate and remove all 3 pegs using the regular camera view from the 2 endoscopes. And so results from this trial were used as a control to compare against our experimental data, which was also collected in another 5-minute interval. This time, however, students were given a VR picture and asked to study the interior of the box for as long as they liked. And using a time comparison between the time it took students to remove all 3 pegs using the standard view from the 2 endoscopes versus the time it took them with the VR assistance, um, as well as results from a post survey that they had all taken, our data was analyzed using various statistical analyses, which will be discussed in the following slides. And so this is a video of the interior of the box. We had given students a Google Cardboard, but obviously for purposes of us showing you, I'm just gonna have to drag around the video. So you can kind of see the cutouts that we had made within the box itself, and students were given free range for as long as they have liked to, as long as they liked to study the interior of the box and try to locate where the openings were. And they were not given this view when they did the control experiment.
Our primary aim was to test whether the true mean number of pegs removed from the simulator improved with the addition of VR imaging of the practical. Letting mu1 equal the true mean of pegs found in the control trial, and mu2 representing the true mean number of pegs removed in the experimental trial, we set up our null and alternative hypothesis. In our null, we subtracted both mu's to represent that there would be no difference between the trials. And in our alternative, we mu1 minus mu2 to be less than 0 to represent that our second trial, the experimental trial, would have a better result in removing the pegs. We used a predetermined significance level of 0.05, and using a 2-sample unequal variance one-tailed t-test, we determined that our p-value was less than our predetermined significance level of 0.05, leading us to believe there was significant evidence to support the alternative hypothesis and reject the null, leading us to conclude that the true mean number of pegs removed from the simulator will improve with the addition of VR imaging. An interesting result in our data that is a commonly asked question among many laparoscopic researchers is, will history of video games or sports throughout childhood lead to better performances in surgeons? In our application, the true mean number of pegs removed. We compared respondents who said yes versus no to whether or not they played video games or played sports in their childhood, and then compared those results to their success in the practical. Once again, we used the predetermined significance level of 0.05. Our t-test proved that our p-value was less than 1,000th, much lower than 0.05, meaning that there was a lot of significant evidence to support that history of video games or sports will improve the true mean number of pegs removed from the simulator. If you look at our box plot, you'll see that the highest value of the no respondents was lesser or equal to than the lowest value of the yes respondents. This points to the reasoning why our calculated p-value was so low, less than 1,000th, leading to statistically significant results. One of our largest worries when creating this box was all of the moving parts it incorporated. Our box includes 2 moving endoscopes and a VR camera, and we were worried that the perceived level of nausea in participants would be high. However, our results contradict what we initially thought. In our post-survey, participants answered whether or not they felt nausea or other symptoms after completing the experiment. As seen in the bar chart, the mean, median, and mode fall within the first bar, indicating no nausea. This finding is significant as we continue to conduct further experiments. Knowing our current model does not harm the operator or surgeon is valuable to the continuation of this area of research.
Within the post-survey, participants will also ask whether a VR photo and other operations will have a
Michael, I
positive
think
or
you're
negative.
muted. Oh, I'm sorry.
Sorry, I'll begin again. But within the post-survey, participants will ask whether a VR photo and other operations will have a positive or negative impact on their performance. Based on the pie chart shown in the slide, a majority of students, 93%, stated that the inclusion of a VR photo would possibly affect their performance, while a smaller group, 7%, stated that there would be a negative impact. This data provides useful information as it could be used to interpret the overall effect of VR on the outcome of certain operations. If surgeons were given the time to observe and familiarize themselves with the surrounding they are operating on, it would perhaps produce a higher rate of success in comparison to surgeons that are only able to study their patient's body through imaging. Due to the length of each trial, we were only able to conduct a small sample size of laparoscopic students. In future works, testing more participants would yield a larger pool of data to work with, allowing for a more accurate representation of the general public. Additionally, due to a lack of resources, we were unable to use a VR as our main endoscopic camera. If this research were to be conducted again, replacing the exterior endoscope with a VR camera would yield a more accurate simulation of a VR laparoscopic procedure. The use of a VR camera would benefit future laparoscopic surgeons as at the 360 view of the patient's body will allow for more flexibility and awareness during the operation. This would allow surgeons to perform with a higher degree of safety and precision, and could be used to train surgeons with a more realistic simulation, which would ultimately lead to higher rates of success and patient happiness. Additionally, to improve upon this research, future experimentation should include different exercises to determine whether VR possibly affects laparoscopic performance. Although we found some useful data in this research, we cannot be certain that the results will apply to all procedures. Different exercises may show which procedure would be optimized with the use of a VR camera and which wouldn't. We would like to thank the faculty member in charge of leading the laparoscopy class, Dr. Marty Harble, for giving us the opportunity to participate in laparoscopy, along with the head of the pre-health department, Dr. Richard Senker, for funding our research and providing us for the resources for our class.
Thank you so much for presenting. That was really good. Now we can open the floor to the judges to ask any questions that they have. So go ahead.
So you said that this is a low cost method. What would be the cost for one of these setups? Yeah, for a medical student, for instance.
We wouldn't suggest it be used for a medical student. It would be an institution that would have to buy it because you can use it for more people. But our cost after all materials were collected, including the hose, the tote, our Maryland's, trocars, and the camera, was $140. So we would say max of 150, which is much less than $1,000 current simulators cost.
Thank you.
Nice, and good job, you guys. One question I had was, it looks like we were saying that this VR technology is helpful for laparoscopic type surgeries. Is there any evidence showing that VR could be helpful in other kinds of surgeries, possibly more invasive surgeries as well?
Yes, there are papers that have discussed this. However, the reason why virtual reality is most useful for laparoscopic and endoscopic procedures is since these procedures often have a lower range of view compared to more invasive procedures. So the utility is more useful for laparoscopic procedures. But thank you for the question.
Nice, thank you.
Do the judges have any more questions? Okay, if anyone else in the audience wants to ask a question, you can go ahead and ask it now, so feel free. Okay, if we have anyone, stop me if you have a question, but if we don't have any more questions, thank you so much to the presenters. Really enjoyed your presentation. And we can go ahead and get started for the next presentation. So yeah. Okay, so our next presentation is by Catherine, Thamai, Gabriel, and Ruth from Baylor University. And before we begin, do the judges need any more time to finish writing your feedback?
Maybe like 5 seconds.
Okay, yeah, go ahead.
All set now. Thank you.
Okay, so for the presenters, you can go ahead and pin me if you would like to see my little visual time warning. But yeah, okay, so just to kind of repeat, we next up we have Catherine, Thamai, Gabriel, and Ruth from Baylor University. So yeah, y'all can go ahead and start whenever you're ready.
Good morning. Today we're going to be analyzing the effect of fluorescence on efficiency and training of laparoscopy procedures. And then we'll get into the rise in history. So, the essentials of laparoscopy were initially introduced in 1902 by George Kelling, and since then, laparoscopy has evolved to a minimally invasive surgical procedure in which a fiber optic instrument is inserted through the abdominal wall to view the organs or to perform a surgical procedure. The discovery of new surgical procedures, more specifically in laparoscopy, provides a multitude of opportunities to discover new strategies and methods that could alter and enhance these procedures for improved efficiency and accuracy. And now we go into the benefits. Since laparoscopy is a minimal invasive procedure, in patient terms, laparoscopy surgery has the advantages of avoiding large open wounds or incisions, and thus decreasing blood loss, pain, and discomfort. The fine instruments are less apt to cause tissue trauma and blood loss. These benefits also help decrease the recovery period and hence lessen the risk of bone loss, muscle atrophy, and urinary retention. Laparoscopy surgery also means less direct contact between the surgeon and the patient, and hence that is less risk that the surgeon will acquire a virus infection from the patient or vice versa. However, with these benefits, this procedure also comes with disadvantages. With the loss of haptic touch and mobility, it is difficult for surgeons to discern structures needed to be treated. Though laparoscopy surgery has undergone rapid innovations, one practice that has remained largely unchanged is a sole reliance on the reflected white light for the surgeon's visualization. This is where fluorescence plays a role. The application of fluorescent imaging in this spectrum has thoroughly been investigated and is shown to be an effective imaging tool that enhances the identifications of structures, improves complete removal of diseased tissues, and aids in avoiding unintentional injury. The next slide shows the influence of fluorescence. Over here, fluorescence is targeted in cytoreductive surgery for intraoperative visualization in open surgery. The image on the left, the image in view shows the localized region in the peritoneal cavity of an ovarian cancer patient. As noted, on the left is what the surgeon sees with the naked eye, and on the right with fluorescent dye. It is much easier to view the areas that need to be treated with the fluorescent dye, and this aids the surgeons in the surgical procedure. So how does it work? Fluorescent imaging involves the use of dyes containing molecules. When exposed to light, energy is released as photons visible to the human eye. Indocyanin green, or ICG, is commonly used as a fluorescent dye in laparoscopic surgery in recent years. When injected, ICG binds to plasma proteins, travels through the bloodstream, and progresses through the bile duct, allowing for observation with the near-infrared light as it travels through the body. Through this binding, fluorescent dyes such as ICD can allow for enhanced visualization of the anatomy, improve precision and efficiency during the surgical procedure.
So shown here is a comprehensive list of laparotomic and laparoscopic procedures that are either testing the application of fluorescence or that have fully applied fluorescence for its numerous benefits. Applications of fluorescence range from mapping and imaging to surgery assistance and tumor marking. Synthesis of laparoscopy and fluorescence. Over the past few decades, the applications of fluorescence in laparoscopic procedures have greatly increased, and the technology has also seen rapid innovations over the same time period. However, comparisons between the success of fluorescence-aided laparoscopy and laparoscopy that is reliant on conventional high-intensity lighting have not been widely studied. Gaining more insight into these comparisons with consideration of surgeon preferences and the surgical landscape might help identify applications for greater efficiency and accuracy. Due to the vast differences between conventional and fluorescence-guided laparoscopy, effective and inexpensive training applications are necessary for widespread implementation. So our objectives. Our study seeks to analyze the differences in effectivity between fluorescence-guided and conventional laparoscopy for identification of structures during laparoscopic procedures. This is achieved by simulating the surgical environment of a laparoscopic ovarian cystectomy procedure under varying lighting conditions. Through this study, we are also pursuing a novel, inexpensive training apparatus that may be used for widespread implementation of fluorescence in laparoscopic surgery. So about our training apparatus, the entirety of our training apparatus is contained in an opaque plastic box that measures 18 1/8 by 12 1/4 by 7 inches, and it contains a high definition camera that is used for visualization of the simulated surgical environment. And then on the lid surface of the box, there are 2 Maryland dissecting forceps that were inserted through trocars on specific established port locations, and these port locations were kept constant for all of the test trials. Inside the box, we have a uterine ovarian model that was placed at the camera visualized end of the field, and the light source varied between conventional lighting and fluorescence. So on our laparoscopic simulators, on the left side, you'll see the field of view for the natural lighting box. The box is completely clear, which allows natural lighting to enter the field of view. And you'll see our styrofoam ovarian model with red cysts placed on the surface of the model. And then these red strings running over the model and in different directions over inside the box. These are used to simulate blood vessels that you might find in an actual surgical field of view. And then on the right side, you'll see the fluorescence box, which is completely blacked out with black spray paint. This prevents light from entering the box. And instead of red cyst models, we have fluorescence infused models that are placed on the cyst, but we also have the blood vessels simulated with string in that box as well. So to select our participants, we chose a participant pool of 22 pre-medical undergraduate students in Baylor University. All of the participants were enrolled in a class called Bio 1v90 or laparoscopy techniques. And in this course, they've all been trained in various laparoscopic practices, including a pegboard exercise, and they're all proficient in the intracorporeal knot suture. And because our study only included participants that were enrolled in the Bio 1v90 course, we established a baseline level of dexterity and experience to prevent any outliers. So more into our procedure and testing. All of the participants were placed into 2 experimental groups, and these groups determined which laparoscopic simulator, either the conventional lighting or the fluorescence-guided box, they were assigned to complete first. This was done to mitigate the learning curve that the participants may be able to develop, especially because both of the boxes have the same procedure. So we wanted to avoid that learning curve maybe affecting our results. And the task of the participants was to remove 3 simulated cysts, as you saw in the image, through retraction, and they have a time limit of 90 seconds. The locations of the cysts were not specified to the participants, but they were kept constant within each trial and within each box. And the same procedure was implemented for each simulator. And then our data collected was the time that was required for each participant to remove all 3 cysts, or as many cysts as they were able to remove within the 90-second time limit. Damaging the blood vessels, which were simulated by the string, was designated as an error, and the frequency of this error was also recorded for each participant.
In order to account for outside variables that could impact the testing process, we had each participant fill out a survey before they took part in our research. Since our research was dependent on information pertaining to site and how much one could see or recognize structures in the box, we determined that it would be important to survey on whether or not there were factors that could impede one's success due to lack of sight. So we asked each participant whether they were required to wear glasses or contacts and whether or not they were wearing it when participating in the research to determine the credibility of their data point. Additionally, since lighting was considered when conducting our research with the use of fluorescence, we also had participants indicate whether they were sensitive, somewhat sensitive, or insensitive to light, since this could have been a contributing factor that impacted their success during each trial. We also asked participants on whether or not they had heard about our procedure before they came into tests or run our trials, because previous knowledge could impact or give individual participants an upper hand, and it would impact the control of our experiment. And then additionally, after they ran our trials, we had them fill out a post-lab survey, and we asked them which box was easier personally and for them in terms of identification to understand individual perceptions of participants without regard to the time they took on completing each box. Additionally, we asked them whether or not there was something specific that they found different or that might have impacted their ability to complete the tasks in each box that we might not have considered. This allowed us to know of additional information in each trial that could have impacted the student's success in performing our experiment, such as whether or not they found the models of arteries and veins to have impacted their performance on each of the boxes. So now we're going to go on to understand and analyze the data that we collected. So we had a total of 22 participants, and we plotted the total time it took each participant to complete the tasks in the regularly lighted box as well as the fluorescent box. So the fluorescence is indicated by the green dots, and the HD lighting is indicated by the lighter white dots. So since we wanted to compare the significance between the time it took to complete the tasks in the different boxes, we determined it would be best to compare and analyze our data using t-tests. So we determined that our data represented a paired t-test, and our t-value came out to be about 2.805 with 21 degrees of freedom. And since our p-value was less than 0.05, we determined that our data was statistically significant, which allowed us to support our alternative hypothesis and reject our null hypothesis. Additionally, we also split up our data based on information we got from our post-lab survey. So based on individual preferences between whether participants preferred fluorescence, performing the experiment under the fluorescent lighting or regular lighting, and this will be further analyzed in the following slides. And then lastly, we also performed quantile distributions to once again analyze our data and the variability within our data. So in figure 1, as you can see, which was this figure right here, the average time that it took a student to complete the natural light box was 48.47 seconds compared to an average time of 36.89 seconds under fluorescent lighting conditions. So fluorescent lighting conditions on average was faster than natural lighting. So with a statistically significant value, the discrepancies in times were associated with, we were able to determine that the discrepancies were associated with improved lighting and visualization under the fluorescence box. And yes.
And as indicated in figure 2, considering participant preferences for specific lighting sources, the discrepancy times for each were regular lighting apparatus was 42.63 seconds versus 49.68 seconds. And so and the fluorescent training apparatus has 52.83 seconds versus 31.01 seconds. Therefore, surgeon preferences must be taken into account for adequate success in the process. And as indicated in figure 3, there's low levels of variability for fluorescent times comparatively to regular lighting. So that average is statistically significant in both sets. With growing uses of fluorescence for surgical landscapes, training for and preparing for fluorescent landscapes is difficult. And so providing sustainable and cost-effective and accurate models for fluorescent while seeing its effectiveness may suggest future field in fluorescent training. And in the surgical environment, there's often more obstacle than that is presented in this apparatus. And with errors such as varying camera angles and external inconsistencies with lighting, there needs to be additional testing to potentially employ the results of the study in the medical field. In this study, we determined the feasibility of performing laparoscopic resection of cysts. Therefore, further on, we can use this in more gynecological procedures. And fluorescence-guided laparoscopic surgery can be utilized for resection of metastasis, as well as primary tumor resection. Intraoperative fluorescent imaging offers the benefits of high contrast and specificity, as well as the absence of ionizing radiation, which can be potentially useful in elderly patients. And since this research has determined that fluorescence is effective in identifying structures in laparoscopic procedures, a future area of study could delve into different methods of fluorescence labeling to determine which method is most safe and effective. The testing of fluorescence could be implemented in different surgical procedures and processes to determine its effect and efficiency in those procedures. Are there any questions?
Thank you guys so much. Okay, the floor is open for judges.
That was a really good presentation, super interesting. I had one thing that I wanted to kind of touch base on the quantile, I believe, analysis slide. You showed us some box plots, and it looked like there were some significant outliers in one of the conditions. I was wondering if maybe you could kind of walk us through that or explain what you saw with that data.
Okay, Ruth, do you mind going back a little bit?
Right there.
Okay, yes. So on the right is our fluorescent models, and we did have people that found it difficult to complete the fluorescent model. But as you can see overall in our quantile distribution, there's an averagely there's a higher rate of people that are taking longer on the normal HD lighting. And so there are some outliers as individuals were incapable of switching over to and adjusting to identifying the cysts with fluorescent, but that's just normal training and the learning curve. And so that's why we do have statistical outliers.
Okay, very interesting. And they were able to give you that reasoning that it was hard for them to tell? Very interesting.
Yes, in the post-lab survey, they did indicate that it was more difficult to complete the fluorescent in terms of learning curve. And almost every single participant stated that it was difficult to complete it once in a while. But averagely, we were in a lower rate with average times in completing the actual full procedure.
Awesome, thank you.
Okay, I think I have a couple of questions. The first one is probably an easy one. Is this technology typically used in addition to white light or instead of the white light?
It is used instead of white light. So fluorescent and FCG is used instead of the normal white light that we normally see in laparoscopic training procedures.
Okay, sounds good. Thank you. And then the other question was this a crossover design, or did you split the group of 22 pre-med students into two groups of 11?
We did crossover design. So Ruth,
Okay.
could you possibly go to the slide right before with the graphs? That one. So you can see that we used almost, do you mind going one more before, Ruth, for me, please? Yeah, so we did have 22 participants, and we tested them on every single box, but it was randomized on which box they tested first with.
Okay, yeah, that's good to know. Thank you so much.
Thank you so much.
Do the judges have any more questions?
I had one more just out of curiosity. So you talked about, I don't know that we saw much of the results having to do with blood, whether they touched blood vessels or not. How does that work with the fluorescent technology? I mean, it seems like a lot of the times just the cyst would be fluoresced, right? And then, yeah, are there more issues with rupturing blood vessels, or yeah, how does this technology work in that sense?
So for our purposes, we were just trying to provide obstacles that are normally seen in actual body cavities. So we employed the use of strings as blood vessels, and of course they're typically not lighted up because even in tumor resection, only the tumor itself and the cyst itself are lighted up with fluorescence. So of course the surgery is to remove the cyst or the tumor, but we do want to provide obstacles that are normally seen within the body cavity and in typical laparoscopic procedures.
Thank you. Yeah, this was super interesting.
Correct me if I'm wrong, but kind of like another part of the question that you're asking there, Katie, is if the lights are completely off, do they have more trouble maneuvering around those non-fluoresced vessels?
Yeah, or structures. I mean, yeah, are there any cases where like a surgeon perhaps might touch something they're not supposed to because it's dark? Does that make sense?
Yeah. So we do have typical lighting structures, but when we're using normal HD lighting, it is a brighter light. So there is some lighting, even with fluorescent, that is going to help guide us and see the blood vessels. But when we're using just bright white light, there is a typically larger light, if I'm making sense. It's larger light, and so that's going to impede our identification of cysts. But with fluorescence, it's just a smaller light that we have. Even in there, we did have like some light coming in from the top that helped identify and see those little blood vessels, which is typical in body cavity. You can't have complete absence of light because that's atypical in normal surgical environments.
Yeah, that's good to know. Thank you so much.
Thank you.
Okay, do the judges need any more time to finish up writing feedback?
Maybe 20 seconds.
Okay, go for it.
Was there another question?
Oh yes, I had a question myself. I was wondering, how much time was deducted if they touched the arteries, and why, and that baseline that you guys chose, why did you choose that time?
Do you mind repeating that question? I'm so sorry, I couldn't hear you.
How much time did you guys deduct from each participant whenever they tested an artery? And I know you guys said that there was like a baseline time too that you guys set, and so why did you choose that time?
Okay, so there was no baseline time that we set. We talked about baseline experience, and so almost every single individual in that laparoscopy class, Bio 1B 90, has a basic level of experience because we've been training for almost a semester and a half. And so to answer the first part of your question, what was your first part of your question? I'm so sorry. Oh, yes. We didn't deduct any time for blood vessel nicking. It's just that no participant had chopped off any of the blood vessels between both of them. So we didn't think that was important to put into the information.
Yeah, thank you.
Okay, I think we're going to go ahead and get started with our next presentation. Our next presentation is Emily from UTD, and you can go ahead and start sharing your screen and go ahead and get started whenever you're ready.
Okay, let me share real quick. And then present. Can you guys go ahead and see my screen? Can you see my screen?
Yes, we can. Go ahead and start whenever.
And you can hear me, correct?
Yes.
Okay. All right. Hi, everyone. I am Emily Buchanan. I am a junior at the University of Texas at Dallas. I'm a double major chemistry biology student, and I'm very excited to present my research on the importance of implantable cardiac device cybersecurity, a study of patient perceptions and concerns. So before I get into the research, I want to give you a brief introduction to the types of cardiac devices we studied in our research. We focused on 3 types: loop recorders, pacemakers, and defibrillators. Loop recorders are a small monitor, which is implanted about 1/2 a centimeter under the skin in the right above your pectoral muscle. And it serves to collect information about arrhythmias and heart rates. Pacemakers are a much more common type of cardiac device, usually the one people think of most when they think of implantable cardiac devices. And these are the devices which deliver small amounts of electricity to help maintain your heart rate. So they are planted subdermally, just above the pectoral muscle, and there are 3 leads which go directly into your heart to deliver electricity to maintain proper heart rates. The third type of device we study is a defibrillator, which is implanted the same as a pacemaker. But in addition to the ability to pace, it can also deliver high voltage shocks, which can help bring someone out of cardiac arrest. So if you've ever worked with a AED defibrillator, this is a miniaturized version of that, which is actually implanted. So when we talk about cardiac devices, there are a couple of cybersecurity risks which are particular to having a device implanted within you. Of these, the first is just a data breach. So within implantable cardiac devices, we store particular health information, including patient name, date of birth, social security, date of implant, and then information about the actual arrhythmias and heart rates that are occurring. So one type of attack that could occur is for a hacker to access this information. Another type of attack model is called battery depletion. And so what would happen with this is normal devices last between 1 and 10 years. However, depending on how the device is set up and implanted and the parameters set upon it, that battery can be depleted much faster, anywhere between 2 and 7 years. And so what we can imagine is for a hacker to go into your device, change the parameters such that your battery depletes very fast or it depletes without your knowledge. And that could result in either your device completely shutting down when the battery is depleted, or really high costs associated with explant and reimplant, ranging from $20,000 up to $100,000, depending on the type of explant and reimplant procedure. In addition, there could be malicious device attacks, which is probably what you would think when you think of cybersecurity risks. A case like this would be an example as have been popularized on a couple different television shows where the attacker goes in and they actually change the device parameters itself such that it paces you extremely fast. It doesn't pace you at all and you have no heart rate. Or in the case of a defibrillator, it could deliver high voltage shocks, which do not feel good. And then the fourth type of attack would be just a device malfunction. So with all these devices, there are certain safety parameters which are set up such that in case of the emergency or in areas where the device may not function properly, i.e. in an MRI, very strong magnetic field, the device goes back to what we call factory settings of 60 beats per minute. And so you can imagine that, if you have an attacker who goes in and messes with too many things, the device might either shut off completely or revert to its factory settings. So with the risks associated with an attack on a device, we wanted to gauge what patients actually knew about cybersecurity and a couple other things in the study. The first was just knowledge. Do patients understand cybersecurity? Do they think it's a risk? What do they know about cybersecurity in regards to what do they know about their device? Our second objective was to assess concern. Do patients worry about cybersecurity? Do they think that their device is going to be attacked or can be attacked? The third thing we wanted to learn was dependence. As there are different types of devices and as device implantation time or your time with your device in your body changes, does that concern and that knowledge change? And then the last thing we wanted to assess was education. As we want to bring to the light knowledge of device cybersecurity and improve cybersecurity methods, we wanted to understand, do patients want to be educated about this? Is this an issue they think is important? And how do we approach that? And so that brings us to our study. We designed a cross-sectional survey administered to 100 patients consecutively in the clinic. Our average age of participant was 66 years. Most of our patients were female in this study. This was a distribution of device types. The majority had pacemakers with 20% and roughly 20% having loop recorders and defibrillators, which is pretty standard and was what you would expect with a typical clinic distribution population. In addition, this is the distribution of the duration of implant. The majority of patients had their device between 1 and 5 years, which is typical given the amount of time a device can last. that brings us to our results. The first thing we wanted to assess is knowledge. How much do patients know about medical device cybersecurity? So the first thing we asked is, have you ever heard of medical device cybersecurity? And the results here I think are pretty stark. We had a large majority, 62%, reporting that they had never heard of medical device cybersecurity before. But with that, we wanted to assess the difference in knowledge between just knowing about the properties of the device versus knowing about the properties of medical device cybersecurity. Because presumably, if you don't know anything about your implantable device, you probably don't know anything about the cybersecurity of that implantable device. So the first thing we did is we asked patients, how much do you know about your implantable medical device? And as you can see, most patients report that they know what their device is and how it works. However, when we ask the same question with the same metrics regarding device cybersecurity, we can see that that distribution drastically shifts from knowing what it is and how it works, or working knowledge, to not knowing anything about their device or about medical device cybersecurity, which suggests that there's a large gap in patient knowledge of this area. The second thing we wanted to assess is concern. So we asked patients, do you think your device is hackable? And what we saw in this is that a little over 80% either know for sure, think, or have no idea whether or not their device is hackable. And so to me, as a researcher, that would suggest, well, if people think or know or don't know if their device is hackable, they're probably worried about it, right? But actually, when we asked people if they worry that their device might be attacked, 70% reported they weren't worried, which was a really interesting finding. And one thing which might shed light on this is that when we asked people how common or how often they thought the device attacks occurred, they correctly said that either they don't happen or they happen very rarely. And so that might address kind of this disconnect between knowing whether their device is attackable or not and being worried about it. However, what this suggests is that if device attacks either become more common or are publicized more, we might see a drastic increase in the distribution of patients who are worried. The next thing we wanted to assess is whether or not dependence, so the type of device they had, affected how much they were worried. And one way you could think of this is loop recorders just record information. Pacemakers maintain heart rate. Defibrillators maintain heart rate and can deliver high voltage shocks. And so what's interesting is when we look at that distribution from least involved type of device to most involved type of device, that percentage of patients which worry about device attacks increases. We also assessed whether or not concern changed based on the duration the patients had with their device, or how long it was inside their bodies. And so what's interesting about this is patients who had their device for less than a year were the distribution of worried patients to not worried patients was much larger than patients who had their device for more than a year. And perhaps an explanation for this is patients who just got their device implanted had to undergo a surgery. This is a brand new device. It's possible that they are experiencing some changes symptomatically on a day-to-day level as we adjust device parameters and optimize it. So perhaps there's just a novelty factor which contributes to that increased worry for patients who've had their device for less than a year. The last thing we wanted to do is assess how patients wanted to be educated, or if they wanted to be educated at all about devices cybersecurity. So when we asked patients that, we saw that a majority of patients would like to learn more about their physician from them, which intuitively I think makes sense. If you had a surgeon who's implanted this device, who is in charge of managing it, you want to understand and learn from them how you should take care of your device and the cybersecurity associated with it. And additionally, I was rather surprised to find that 36% wanted to read more about it online, which as a healthcare professional is a little concerning, because when you do just a general Google search about implantable device cybersecurity, a lot of the information out there is not well structured, and it is phrased so that it scares participants and scares patients more than it's helpful. In addition, I would like to note that we did have a percentage of patients, 14%, who did not want to learn about device cybersecurity. So in conclusion, we assessed 4 things. We assessed knowledge, and we saw that there's a significant difference between patient knowledge of their device and patient knowledge of device cybersecurity. We also saw that a majority of patients report that they do not know anything about medical device cybersecurity. With regards to concerns, we saw that although only 20% of patients believe that their device is not hackable, only 70% are worried. We believe this is likely due to the fact that most patients believe that attacks are very rare or do not occur. For dependence, we saw that patients who are more physically dependent on their device express a greater concern that their device is hackable, as well as patients who've had their device for less than a year have a greater degree of concern than patients who've had their device for longer. With regards to education, we learned that device cybersecurity is important to patients, and that patients would like to be educated by their physicians and online. Additional materials and resources need to be compiled so that patients can access this accurate information. So kind of to wrap up, I'd like to highlight a few questions which I believe still remain regarding this issue. The first is with current device technology. What cybersecurity measures can we incorporate to ensure that devices right now are cyber secure? In addition, with regards to regulations, what safeguards do we need to put in place to make sure that device companies make devices that are cyber secure? With regards to patient education, what information should we convey to patients? And how should we do this in a way that is meant to educate and not scare patients? In addition, on the education side, there's a growing need for physician education, as several research studies have showed that physicians in general are not concerned or do not believe that cybersecurity is an issue in the healthcare sector. Lastly, with regards to current devices, how can we both analyze and ensure that current risks are addressed? And how should routine security evaluations be performed to make sure that patients' devices are cyber secure on a daily basis? Lastly, I'd like to acknowledge the people who made this research possible, both my university and heart rhythm specialist and Dr. Dale Yu, who are the clinic and doctor who sponsored this research. In addition, I'd like to thank Medical City Dallas, who was our IRB on this study. And with that, I will take questions.
Okay, great presentation. Thank you, Emily. How common are cybersecurity issues with implanted devices? Is there like a prevalence rate that you have or know of?
Yes, so I had a timeline of cyber attacks on the last decade, but I had to cut it just due to the time constraints. There have been a handful of cybersecurity medical attacks within the past decade, around 15. However, most of those were either ransomwares, where they withhold services from a hospital, such as electronic medical records, so that the hospital cannot use them until a fee is paid, or they just deny services outright. There have been about 15 of those in the past year, both in the United States and Europe. To date, there have been no known malicious attacks on cybersecurity devices. However, in 2017, the FDA released a statement recalling several thousand pacemakers from St. Jude Medical, and then 2 years later, Abbott, for a lack of cybersecurity on the devices. And there have been several cybersecurity advocates who have demonstrated that devices can be attacked, and that malicious attacks such as battery drains and shocking a patient remotely can happen. It is feasibly possible, although there have been no reported cases. Does that answer your question?
Yeah, thank you, Emily.
So it's I would just like to add, so it's one of those issues where it is not mainstream yet. There have been no attacks, but because the risk of attacks and the severity and the consequences thereof are so high, this is definitely one of those issues that we need to be on the front end of rather than the reacting back end.
Excellent. Yeah, thank you so much. Yeah, that was good to know. I didn't know much about it until I read your abstract. So thank you. Also, tell Sophie hi for me. She's an old friend. We used to pole vault together.
Really? I
Yes.
will. Small world.
That was super great. And that was one of my questions too, was just how prevalent that is, because I hadn't heard about that either, but it totally makes sense that that could happen, and it's horrible. I also had some questions. Did you collect any just qualitative data on their answers to some of these questions? So the one that kind of stuck out in my brain was the 14% reporting that they didn't want to learn anything about their device or about cybersecurity. Were you able to ask them why, or just their reasoning?
So unfortunately, with research which is delivered in a medical setting, all questions asked must go through the IRB board for approval. And so they look at all of our surveys. And so there are some serious limitations in that regards to what we can ask. So we couldn't ask qualitative. It was a paper survey, so I had some interesting write-ins here and there. The most notable, I think, was I asked patients whether or not they were willing to pay money for cybersecurity additional features. And most of the write-ins were, no, my device company needs to take care of that. But no, I was not able to kind of engage in a discussion with them following about their answers. It's with surveys given in the medical setting, there's blinding requirements and consent requirements, which kind of prohibited that.
Makes sense, but very interesting. Thank you very much.
Are there any other questions?
I have a quick question. So in the future's areas of studies, how do you think that we can increase physician education on cybersecurity and stress the importance of mitigating the threats of cybersecurity on implanted devices?
Yeah, that's definitely a good question, which holds a lot of weight. I think probably with regards to mass distribution, the easiest way to do something like that is through continuing medical education credits, because physicians are required to attend seminars and courses to keep up their current credentialing. So for physicians who specialize in medical devices, such as cardiologists, some people who work with insulin pumps, I think that continuing medical education seminars would be a great way to increase knowledge. But in addition, I think in medical schools, there needs to be a discussion about how cybersecurity plays a role in healthcare and kind of the importance, which is actually something that we're seeing a growing presence of, especially with regards to hospitals, because ransomware attacks are extremely costly to hospitals. So they have definitely been cranking down in the past 10 years on educating their physicians and their medical students about how to avoid easy cybersecurity risks. Does that answer your question?
Yes, thank you so much, Emily.
Okay, do the judges need any more time to finish their feedback? Okay, then we can go ahead and get into our next presentation. Next up, we have Sai from Baylor University. And you can go ahead and share your screen and get started whenever you're ready.
Thank you, Sophie. Can everyone see my screen?
Yes, we can see your screen.
Awesome. Good morning, everyone. My name is Sai Sagireddy. I'm a freshman at Baylor University, and today I'm really excited to share with you the Waco Healthcare Accessibility Project that I've been working on this semester and last semester. So a little bit of background on our city. So the US Census Bureau from 2016 has shown us that over 29% of Waco's population lives below the federal poverty line. The federal poverty line states that if a family is surviving 200% below their supposed income level, according to the US Census Bureau, they are classified as homeless. This specific population have resources available to them, a lot of resources from different organizations in Waco, but they don't know what they are and they don't have access to them. Since they're not aware of them, they don't know that these exist and they're unable to use them. To combat this problem, I authored the Waco Low-Income Healthcare Resources Guide. This is a guide that contains over 90 healthcare programs, 15 different programs specifically with nonprofit organizations, and over 90 healthcare opportunities that this population could tap into. These programs cater to disadvantaged Waco residents. And I wanted to create this because there was no media that connected this specific underserved population to those programs. And when a specific program doesn't receive the audience that they intend for, they tend to go away after 2 to 3 years, because this is funding that has essentially gone to waste. And this specific guide, it will help homeless individuals find their specific healthcare needs. It will help homeless shelter directors as well as student organizations and health groups who are looking to connect these populations to healthcare resources. These are some statistics. As I said before, we have over 90 medical institutions within Waco in this guide, over 15 healthcare programs, and a potential audience of 15,000 individuals living within Waco. So to compile this guide, I first had to get a lot of data in. So with each healthcare opportunity, I placed the name, classified them whether they're a federal qualified health center, if it's a free resource, or if it's a resource intended to gain some funding from the patients, the website, the hours, contacts, services, the paperwork that they need, whether they need a letter from their homeless shelter or an individual that they know. Next, we moved on to compilation of all these resources. So the goal behind this guide was that if an individual would pick it up within 2 minutes of exploring this guide, they should be able to find exactly what they're looking for. So this is a snippet from the table of contents. We can see we have all the different healthcare providers in Waco, and with each specific resource, we have a description of what the clinic is, the location, the hours of operation, the contact for the clinics, all the healthcare services that they offer, and a specific map of where they operate. If they have mobile clinics, we talk about how these mobile clinics operate, and we created this database so that it will be like the one-stop source of a specific healthcare resource available in Waco. And currently, it has every single thing available in Waco. And we realized that it may be hard to constantly update a physical guide. So as we are working on our physical guides project, we also partnered with a nonprofit called Prosper Waco, and they have a database called the Waco Roundtable. And the Waco Roundtable is designed to connect nonprofits to nonprofits. So in a case study, let's say the Texas Mental Health Retardation Center, they need more psychiatrists. They would not know how to approach or who to approach to fill this need. So they would go on the Waco Roundtable to contact another resource who could help them. So that would be the Family Health Center. And all of our data within this guide, we have converted it into Excel sheets and spreadsheets, and we have placed them into the Waco Roundtable. So this is a digital partnership that we have been working on this semester, and this has been really, really exciting to work on so far. So we have several community partners involved in this project. First and foremost, Mr. Dale Barron from the Waco Family Medicine. Mr. Dale Barron, initially when we made this guide, we had no idea where we were able to get funding from to make physical copies. And the Waco Family Medicine has so generously offered us a grant to print these guides and allow them to be distributed all over Waco and beyond. Ms. Holly Burchett and Mr. Cuevas Peacock at the Baylor Office of External Affairs, they have been so instrumental in involving the City Council of Waco and getting this guide approved and allowed it to be used by nonprofit and medical professionals. Ms. Tiffany Gray of Prosper Waco is our direct contact at Prosper Waco, who is transferring all our data onto the Waco Roundtable database. Dr. Lauren Barron in the Medical Humanities Department has been exploring the social determinants of health and what else we can include into this guide for future editions. The grant we received from Waco Family Medicine covers printing of this guide for several years as we go on updating it. So we do have a plan on working more to include more resources for this guide. And Dr. Mito Diaz-Espinoza from the Academy for Leadership Development at Baylor, he has been so instrumental in getting this group of people and allowing us to sit down and exactly create a roadmap for this project. So with regard to distribution, the physical guides, we have a digital copy and we have actual physical guides that we have printed so far. And these digital guides have been sent off to various organizations, the Waco Family Medicine, Prosper Waco, Mission Waco, essentially all of these organizations all over Waco. And the physical guides have been sent to Waco Family Medicine, Prosper Waco, all of these, again, the same nonprofits, but in physical format. And after this, we are currently in the process of distributing all of these guides, and we are not done with this project. This semester has grown so exponentially. It has branched into so many different things. So I think the first step that we are currently working on is continuing distribution of these guides. the Waco Family Medicine, they have recently rebranded from the Family Health Center to Waco Family Medicine. So what we have been working on these past couple of weeks is reframing all of this guide into all of their new formats so that the guide will be up to date. We are increasing production of these guides as we are updating it currently. So by July of this year, every nonprofit within Waco will have a copy of this guide. Simultaneously, with our digital partners, we are conducting various studies on the Waco community. Prosper Waco, they are currently looking at the efficacy of mobile clinics within Waco because this is an area that has not been tapped into. So we are currently planning on running focus groups in the upcoming month to see what individuals within the community think about these ideas. And healthcare accessibility, and we are running poverty alleviation projects specifically with Dr. Mark Flynn in the anthropology department at Baylor. We are currently trying to see other social determinants of health to see what other factors are preventing patients to accessing healthcare. And one of the main ones that we found is transportation. Waco has a transportation problem, and we're trying to see, is mobile clinics the solution to that, or is it that we need to create a bus system or a transportation system with the Family Health Center or other resources within Baylor? Thank you so much, everyone, for listening to this presentation. I'll now open up to questions.
Yeah, thank you so much for the presentation. Have you gotten any feedback on the guides? Have you heard any positive stories, or just, I guess, maybe anecdotal stories about them?
Definitely. So these guides have been sent to nonprofits from late December to early January. And I think one of the first positive feedbacks we heard back was from Mission Waco. They came back and told us that they found out about so many opportunities that they did not know before. One of the needs that they have is that they do not have a database of dentists. And our guide has a resource which allows us to map on the different dentists within Waco, and Mission Waco was able to contact these dentists, and now they have a system in place where they can send their patients and they'll receive healthcare free of charge from dentists in Waco. And that's just one of the many things that we have heard. We are still trying to figure out a specific statistical analysis method on how we can map this data to move forward from this. That's something Prosper Waco and I are currently working on, and hopefully by May we'll have this set in stone to measure that.
Thank you.
Very interesting. Yeah, that was going to be kind of my question, is if you've seen any significant increase in utilization of these different providers from that community. But it's very interesting work. Are there different, or I guess, what are your main ways of analyzing, or just visually analyzing the impact that these are making? Is it through just personal testimony, or how do you plan on looking at the efficacy?
So before we started making this guide, we did a lot of literature review, and what we saw was that within communities similar to Waco, a lot of individuals tend to use emergency rooms instead of primary care resources. There has been an underuse in primary care resources and an overuse of emergency care resources, and this has put a strain on the healthcare system. And this guide specifically, when we sent it out in January, what a lot of individuals have been telling us is that there has been a surplus in use of primary care resources. So specifically the Madison Cooper Clinic with the Waco Family Medicine, there have been more patients coming in from East Waco, which is a historically underserved community in the city of Waco. And so far there are testimonies, a lot of testimonies, but we still have not been able to find a specific statistical method to analyze all of this, but we are working on it. And as our new shipment of guides go out in May, we will hopefully have a place and a method to measure that.
Nice, thank you very much.
So are the guides, and maybe I just missed this, but are the guides for nonprofits, or are they for individuals? Or are they for medical facilities? I guess yeah, what were they designed for?
So going into the project, they were designed for a specific individual to use, like a family. If they are looking for a pediatrician, they could pick up this guide, go onto the pediatrics part of it and see which area is closest to them. And the entire guide was designed in the mind of the consumer to be used. But I don't know if it's because of COVID, but what we started doing is that we started giving it to nonprofit professionals and medical professionals. And what we realized is that they find it even more useful for them, so they could refer it to patients. And I think that's why we also thought about the digital platform. So these guides, we're going to place them in nonprofits for the consumers to use directly, for individuals to use. But the digital platform that we're building, that will be used by nonprofit professionals and healthcare workers. So it's going into a two-faceted way where the physical guides will be housed within like the office of a nonprofit for individuals who need them to come and use and return, and the digital side of it will be used by working professionals.
Thank you.
Okay, do you have any more questions?
I had a quick question.
Go ahead.
So it seems like the packets are very helpful for individuals as well. And I was curious to know if you've gone out or had a contact that could go out and go in the highly densely populated areas in which people are living in poverty and could hand these out, or if that's still something you're working on, or if with COVID, that's just an issue altogether right now.
Sorry, you kind of cut off a bit in the middle. Could you repeat that question, please? I'm so sorry.
Yeah, so these packets seem helpful for people and individuals directly living in poverty, but not all individuals can go to the nonprofit organizations that have these packets. Have you been able to go out directly to people or take them to churches, or is COVID an issue right now with handing them out to the individuals themselves?
Yeah, definitely. So this same question was actually brought up in one of our meetings we had last week, and Miss Tiffany Gray in Prosper Waco, we are currently working with her to organize focus groups from specific counties within Waco. And our plan is to get 2 to 3 individuals who we believe to be representative of the population and get their knowledge on, would they say, hey, can you guys access this guide if we house it within this specific organization? Or would you prefer another method, maybe pamphlets? So our focus groups hopefully will let us know more insight on that.
Great, thank you.
Okay, do we have any more questions? Okay, if not, then thank you all to all of the presenters. You all did a wonderful job. And this concludes the Public Health and Psychology Division 4. I can go ahead.